All right, so we are going to start now. Thank you for the patience. So I'm thrilled to welcome Dr. Mitchell Wolfe to UCL for our Health Leaders Voices series. I'm delighted that today Mitchell is coming to talk to us about the CDC and his work globally. Like myself, Mitchell has studied in California. Dr. Wolfe has an undergraduate degree from UC Santa Barbara and a Master of Public Health from UC Berkeley. He has worked for 21 years at the CDC, the Centers for Disease Control and Prevention, and has been the Chief Medical Officer of this organization from 2019 to 2022. He has been acting director of the CDC Washington office and the CDC country director in Vietnam and Thailand. He has been a senior advisor for the U.S. government and has been involved in the U.S. government response to the anthrax attacks. He retired in 2020 from the Commission Corps of the United States Public Health Service at the rank of Rear Admiral. He is now the Global Strategist at PDTI, an organization focused on vaccines, diagnostics, antivirals, and other innovative prevention tools for effective distribution in resource-poor and moderate-income countries. I'm thrilled to introduce this presentation. Please join me in welcoming Dr. Mitchell Wolfe.
Okay, let's see. Do I touch this?
If it is working.
All right. How's that? Can you hear me? Is it working? I can't hear it coming through there, but oh yeah, it looks like it. Okay, great. Hi everybody. I'm really happy to be here. I love coming and talking with students and faculty. I moved from the U.S. to London in December, so this is the first time I'm speaking here. So I'm very excited about it. I've talked to Rodolfo. I want to be sure that I leave time for questions. So my plan is to cover a few topics, but not really in detail, to be able to, and you could feel free to ask me about anything, anything that I cover. Let's see if I can get this. Wait, maybe it's the laptop? Yeah. Okay. So I'm going to talk a bit about my work at CDC and how we look at our global health work through the lens of protecting Americans. I'm going to talk just for a few minutes about my role in my career. Like I said, you can ask me more questions about that later. The CDC's mission and role in strengthening global health capacity, talk for a few minutes about public health and diplomacy, and give you a few examples like HIV and PEPFAR, COVID, Vietnam, Thailand, and working with the WHO. I may not get to all of it, and if I don't, next time I'll be happy to. I'll try and get through all of it, but like I said, I want to make sure I leave room for questions and answers. So I'm only going to spend 2 or 3 minutes on my career, but I did want to say two things. One is that I think in retrospect, a career looks like it makes a lot of sense, but prospectively, I had no idea what I was going to do, and I ended up doing jobs that met my kind of skills and interests. So I could explain to you and make it all make sense, but actually I didn't have a plan going into it. And a lot of what I did was based upon mentors and advice that I got from people who really meant a lot to me. And that was probably the biggest influence I had in guiding my career. So these are people from all over the world who helped, and I could go over them if we have more time. The other thing is I had some personal experiences that really affected me. So this was when I did when I was a medical student, and then I went to India and did some traveling, and I'm pretty sure I had dengue fever, and I got to experience what it's like to get sick in a place that had no resources, and I was misdiagnosed, that really actually affected me a lot in trying to help people in low income countries. Wrong way, sorry. And the other thing that really affected me a lot was, doing hands-on work in countries. And when I was at CDC, we got hired, a group I was with that worked with refugees got hired to work on a national survey in Afghanistan on morbidity, mortality, and injury and mental illness. And that, really cemented my desire to work in low and middle income countries globally, because I saw the impact that we could have by collecting data, publishing it, and then using that for program improvement. So this was we were in Afghanistan we did the first nationally representative multi-stage cluster sample survey there. We sent teams throughout the entire country, and it was in 2000 or 2001, right after the Taliban had been removed, and so it was actually safe for us to go around the country. So we went to villages and did interviews there. And so then, I went to work at CDC, and it's amazing to be able to publish papers that had real public health impact. So that was really my message is, since I'm at a university, I have published papers, not just done like policy work and diplomacy, but we did work that ended up having real impact. For example, on the left there, it was an assessment of urinary metals related to a forest fire. There was a forest fire in New Mexico where the atomic bomb had been developed. And so the population there was very worried that there were nuclear residue, in the air that they were breathing. Were able to prove that it wasn't. I did a study on children who were trapped in car trunks and died, which was horrible. But we were able, as a result of that, to if you go to the U.S. now, every car trunk actually has a release inside of it, and part of it was due to this study. And then this one was heat-related mortality in the United States in various cities, and I did a bunch of heat-related studies. And this was really the beginning when, I think, for climate change, there were a lot of increase in heat-related morbidity, and many cities have now implemented things like cooling centers and plans for heat as a result. It wasn't just this study. There was a huge body of work, but it was part of what we did at CDC. So then, like I said, I was very interested in working globally because of my interests and experiences in the past. And so I went to go work in Vietnam, and I'll talk about that a little bit. I was the country director for CDC Vietnam in Hanoi for 5 years. And then after that, I went to Thailand for 5 years, and I'll talk just a few minutes about that and the work that I did. And then after that, I went to Washington. I came back and went to Washington, D.C. So I'll talk for a few minutes about some things related to the work at Washington, D.C. So for the last 5 years, up until last June, I was at CDC, and I was in the office of the director. I think I have an arrow here. Okay, so first I was the acting director of the Washington office. That's an office that deals with Congress, and I really learned a lot about how governments work and how the U.S. government works. And then I was chief medical officer. So this I wanted to show the two different organization charts in two different administrations to show that things. CDC is we try not to be a political organization, but the head of the CDC is appointed by the president, and the head of the Department of Health and Human Services is appointed by the president. So we are in that structure. So I was, the organizational chart changes a little bit based on administration, but I was chief medical officer reporting to the director in the last two administrations, so Trump administration and Biden administration. So CDC's mission is working 24/7. This is a abridged mission, but to protect America from health, safety, and security threats, both foreign and in the U.S. So we use that mission to justify our global work. So our global work, because we need to justify to the American taxpayer why their tax money is going to work overseas. And I have to justify to like my relatives and to the general public. And it's really good to practice on your mom and your uncle and your cousin who's skeptical. You know, why are we spending money in Botswana? You know, why are you spending my tax money? So I think that COVID has helped a lot to explain that, which is a disease threat anywhere is a disease threat everywhere, and diseases spread very quickly. And the more that you can help control diseases at their source, the lower risk there is to the United States. That's basically, I mean, we talk about it for a few hours, but that is the basic argument there. So we use this mission to justify our global health work. I developed these slides when we were speaking to Congress and when we were speaking, you know, to funders about why we need to work globally. So protecting Americans from disease outbreaks, helping countries become more stable by improving their health, which helps them become better partners, and it helps global stability, and it helps them be a better trading partner, helping build health equity and access for all, building global health security worldwide so that, right, we're trying to help countries prevent diseases at their source. And I will talk a little bit about health and diplomacy. So for CDC, you know, we first started out providing technical support for specific diseases and for specific responses, working on smallpox eradication, eliminating polio. But then things started to change really with PEPFAR and with Ebola, and then most recently with SARS, and also with Zika and flu. But I'll just talk briefly about PEPFAR, Ebola, and SARS. We could talk for a whole semester about all of these, but I'm just going to touch on three of them and bring up a few points because they really change things. Now, before I do, I just want to lay out a few kind of principles. So one is development and technical capacity building. So CDC is not a development agency. USAID is the U.S. development agency. We collaborate with, and development typically provides money for low-income countries, right, to develop programs and systems and health and welfare. We collaborate technically with countries at all income levels to help try to improve their ability to prevent, detect, and respond to disease threats. So we work with, you know, Vietnam, we work with Thailand, we work with Japan and Korea. So we're not a development agency. We've learned through COVID, like I said, that a threat anywhere is a threat everywhere. And actually, COVID did not necessarily originate and spread in the developing world, right? China, Europe were where it really first started, and the US. And health is not just a development issue. There's a new paradigm in what countries want. Low and middle income countries want partnerships. They want to be experts. They want to work with our experts. They want to have qualified nationals. They want to have research institutions. They're developing different disease burdens. Chronic disease is a major problem for them, and they want to be able to address that. And they often don't get funding from outside for chronic disease. The U.S. doesn't really have a national interest in helping I don't want to pick a country, but in helping a developing country in their non-communicable diseases necessarily. And so they want to be able to develop that capacity. And so we're changing the way that we work with countries to help build their technical capacity. And then I want to talk a little about public health diplomacy, because we use foreign policy tools to affect public health and use public health to affect foreign policy. It's a two-way street, and the tools and effects of diplomacy can be used to advance public health, and the goodwill and trust built for public health can help our foreign policy objectives. I'll talk about that specifically with Vietnam in a second. And then the other thing is that typically scientists and diplomats are very different, and they don't necessarily speak each other's language, and scientists often want to have data and just say, look, here's the data, it speaks for itself. It's rare that data actually speaks for itself, and we need people to help translate that. And now I think public health practitioners are learning more to be diplomats, and diplomats are learning more how to speak public health and about data. But it's a real issue that we need to develop, because in the past, I think there was a large separation between the two. So ideally, like I said, diplomats start speaking public health, and public health practitioners start speaking diplomacy, and there's increasing examples of this happening. I have worked on road safety and PEPFAR and influenza, and those have helped improve things like military-to-military relationships. So I'll give one example. When I was in Vietnam, where the U.S. military and the Vietnam military had a history that probably most of you know, and so they couldn't talk to each other, and they were just starting to try to build a relationship. And they didn't trust each other, and actually PEPFAR was the first program where the U.S. military and the Vietnam military worked together and started to build trust, and now they have a relationship that's actually very close, and they work together in military exercises. But they really started by working together in PEPFAR. And this is a picture of me in my most common position overseas, which is banging my head against the table, trying to figure out how to balance U.S. government and foreign government priorities. So I'll give you an example of that in a minute here with Vietnam. So when we were in Vietnam, you know, we were supporting Vietnam to build their capacity for global HIV/AIDS, prevention and treatment. Global HIV/AIDS, we expanded to flu. When flu was, when there was an avian influenza outbreak in Vietnam in 2005, I think, and helped support the government to respond to other public health challenges. And we did that through cooperative agreements, which are kind of like grants, but they involve very intensive daily oversight and collaboration in developing programs. So they had a very strong central government. They were very hesitant to collaborate with the U.S. because of the war. However, 70% of the population there was born after the war, so we had an opportunity. And there was really a need for more investment in health. They needed money, they needed human capacity, they needed people. And they showed that they actually had the ability to implement programs. So this is my slide. I had one of our staff take a picture on the same corner for like a month in a row every day, every few days, because they were implementing a helmet law. And so this is the night before the implementation of the helmet law. So you can see, I don't think there's a helmet in the crowd. Maybe there's one. And this is the next morning from the same corner, 14 hours later, and everyone's wearing a helmet. So we knew that you could implement a public health intervention if you targeted it properly in the country. What they did was they warned people for months that it was coming, and the fine for not wearing a helmet was greater than the price of the helmet. That's how Vietnam did it. Now, the thing about Vietnam is, and this would be us working in any country, is how do our priority in Vietnam was mainly health. There was also education, trade, military relation, but primarily health. The government of Vietnam's priorities were mainly the economy and internal stability and a little bit of health. So how do you marry those? And then if you look at health, the government of Vietnam's priorities were hospital, health insurance, and food safety, and then others you can see there. Ours were HIV and PEPFAR, influenza, Agent Orange, and fish safety. So how did we make those two things come together? So this, again, we could talk about for a couple of hours, but I just will say that the way that we did it was through building trust over years and going, like, this is us with the Ministry of Health at a PEPFAR conference in Rwanda. We went annually to conferences with them. We took them out to dinner. We went to all the meetings with them. We traveled with them in Vietnam. We met with them on a daily basis. We spent years building up trust and trying to see what their priorities are and making sure that when we addressed our priorities, like HIV, we were also addressing their priorities, which were building up the health system. We could talk a lot more about it, but that's my basic summary. And then, so we were able to accomplish by working hard on a multi-year daily basis, starting antiretroviral therapy in Vietnam through PEPFAR. When I got to Vietnam, intravenous drug users were put in correctional camps, and female sex workers were put in correctional camps. Now they have drug addiction treatment cadre. So to me, that's one of our biggest accomplishments, is helping them with the way they deal with drug addiction treatment. Outbreak investigation, COVID was an example where Vietnam was one of the best in the world, actually, in addressing their COVID epidemic. And the bilateral relationship, you know, our relationship, the U.S. relationship with Vietnam is now one of the best. We went from a very difficult relationship to now they're one of our closest friends. And PEPFAR was one of the major, if you talk to any U.S. ambassador over the last 20 years, they'll tell you PEPFAR was the major reason for that. And Vietnam is now a global health security leader. Now just a few fun photos. So we attracted a lot of attention because of the good work that we were doing. So the president came, that's my son next to the president, and he kind of elbowed out my son a little bit. After I asked him what it was like, he's like, well, he elbowed me out a little bit. And then you can see I'm in the public health service, which is not military, but it's a uniformed service. I can tell you what that is, but we developed a very close relationship with the military, who was very happy with us because we were helping the Vietnam military become more comfortable with the U.S. government. I meant to take this out, sorry. We also put on I was in the expat theater company, and we put on a musical. We did Little Shop of Horrors. I was the piano player. That was a highlight for me in Vietnam. And just to show that when you work overseas, you have to live your life, I had a spinal tumor diagnosed when I was in Vietnam, and I had to decide where to go take it out. And I went to go take it out in Singapore, where I had really, really good treatment, and I was able to get back to work quickly. And I'm very grateful I can still walk. So I'm going to talk about it working in another country, Thailand. So Vietnam was or when we were there, it became a low middle income country. Thailand's an upper middle income country, and people often ask, why would you work in Thailand in an upper middle income country? And remember what I said about we're not a development agency, we're a technical agency. And there are many reasons why. First, there are health threats that come out of Thailand. Second, it's a major diplomatic tool with Thailand, and we have a great relationship with Thailand, and a quarter of our embassy there works on health. Third is Thailand does research that has global implications, for example, female sex work and HIV and STDs. So we were able to collaborate with them on work that had global implications. We also were working on Thailand, helping Thailand in their desire to become a regional asset and a regional donor. And I'll talk about that in a second. And the other thing is, even though they're a middle-income country, that doesn't mean that your health system is necessarily at this level across the whole country. And they had needs for developing their health system that we helped them with. So I just want to say, you know, middle income can be driven. You can still have a lot of disparities in income, and there are a lot of needs in the country. I have some pictures here. You know, this is a hotel that we all stayed at. But then, you know, a lot of Thailand looks like this, and we had floods when we were there, and we had rioting when we were there, and a lot of people still have needs, and we were helping the government of Thailand to develop programs for their, you know, most vulnerable population. The reason this slide is in here is because to talk just a little bit about our relationships with countries. So this is once when our CDC director, Tom Frieden, came to visit. And the person, though, at the very right, bottom right, Dr. Tanarak, we had a kind of an agreement with Thailand. We were stationed, our office was in the Ministry of Health campus. And they would assign a high-level person from the Ministry of Health to be a co-director of our office. So he was my co-director for 2 years. He's now the head of basically their CDC. So for relationship building, we have an incredible relationship with Thailand. I know him well, and I can call him up, and he can call me up. So it's really been a great example of developing good relationships with the country through really years of personal relationship building. So one of the things we did was help Thailand become a regional technical assistance provider. And we had countries come to Thailand, and we had Thai staff go to other countries. And invariably, they would say, you know, I remember when we had the Ministry of Health of Zambia and Kenya come and say, it's incredible what Thailand is able to do with the same resources that we have. I can't believe it. We need to go back and reevaluate how we do things. We would never be able to do that by taking them to the US. They could learn other things. So that kind of what we called then South-South collaboration was very important. And these are all the countries that we worked on with Thailand. So this one is a picture of me with our head laboratorian in Ethiopia helping Ethiopia develop their national reference laboratory, basically. All right, I'll talk for a minute about Ebola. You know, the thing about the Ebola outbreak in Liberia is that it changed how the US government looked at global public health. CDC got $1.5 billion. Before Ebola, basically all the money we got was for disease. It was for HIV, it was for TB, it was for influenza. After Ebola, we got global health security money to help countries build their capacity. That's good and bad. The good part is it works for all diseases, so it's really how our money should come. The difficult part is with PEPFAR has been hugely successful, and it has an incredible metric, number of people on ART, and that saves someone's life. There's no other program that has a metric like that. So global health security, we have all spent thousands of hours trying to come up with great metrics to show Congress and the American public like what we're doing and what we're accomplishing, and it's a much more difficult thing, and I'm happy to talk about that. But the good thing about Ebola was it gave us the opportunity to get money to work in general, non-disease specific health capacity building. And then I was just going to talk for a minute about my work in Washington. There were many things, but one of them is work with WHO, because WHO is such a unique and interesting case. I don't know how much you've covered it, but what we have always said, you know, after Ebola, many people were saying that WHO failed. It didn't, you know, do all that we expected. So the international community was trying to decide, do we dismantle WHO? Do we create something else? What our talking point was, it's an imperfect organization, but if WHO didn't exist, we'd have to invent it. So what we did was we decided that we were going to try to strengthen it as much as we could. So we worked very hard to try to get countries together to look at different ways of strengthening the WHO. One of them was influencing the directors. This is the current director, Dr. Tedros of WHO. This is, we were one of the first countries to meet him the morning after he was elected. This is that meeting with the Secretary of Health. I'm next to the Secretary on the left, our ambassadors over on the right. And, you know, our Secretary of Health and Dr. Tedros exchanged cell phone numbers so they could WhatsApp each other. Dr. Tedros loves to text and WhatsApp people around the world. That's his favorite thing. Dr. Tedros and I have bonded because our birthdays are 3 days apart. We're the same age, but our birthdays are 3 days apart. So he'll tell you that if you meet him. But you know, strengthening WHO is kind of also another semester, and I'm happy to answer questions about it. My personal feeling is we have to work hard to strengthen it, but I've been to 8 World Health Assemblies and 8 executive boards, the governing body, and it is just incredible that you have a place where every country in the world gets together and shares their ideas and comes up with, resolutions and decision points and agreements on what they're going to do. That is incredible, and although it's flawed, no one has been able to develop anything better. So I'm a huge supporter, and it's incredibly frustrating. How much time do I have? 10 minutes, okay. So I'll talk for a few minutes about COVID. I think that very often an outbreak happens and we say it's changed everything. COVID, no question, has changed everything. And I don't think we all understand how much it's changed things. But first I'd say that, I'm not going to go over this data. I was just wanted to transition to COVID. So we can all talk about COVID data, later, another time. But, the U.S. took on responding to COVID as a major effort for the entire government. So that was great and difficult because we always wanted attention from the entire government for the public health work we were doing. Now that we got it, everyone's involved. And you can see that around the world. I know it was in the UK. It was basically in almost every country in the world where you now have the political and the public health having to work together. So that's been extremely difficult. Many countries have had problems with it. A lot of ministers of health have not lasted throughout COVID. A lot of heads of CDCs have not lasted throughout COVID. But I think that that's one of the major things that's changed is that now public health is on the radar of the highest levels of government, and we have to figure out how that's going to work. One of the ways is through international health regulations. So I don't know if you've covered that, but there's a treaty that all countries have signed on to that talk about how countries should act when there's outbreaks, like you shouldn't close borders. Well, of course, most countries close their borders, and so the international community is revisiting these international health regulations to see how, based on COVID, we should change them. So we got funding for, we got several tranches of funding, and I just want to talk about one of them. So we got $1.5 billion related to COVID to spend on COVID. Now, that's one-time funding, so we get money in 2 ways. We get base money that we get every year, and then you get boluses of money when there are events. We got 5-year money when there was Ebola. We got 5-year money when there's COVID. It's a mixed bag because you want to use it to develop programs, but if you don't have guaranteed money going forward, there are things you can spend it on and things that you can't. So we were trying to decide, what are we going to do? So in addition to our responding, one of the things I led there was the development of 4 initiatives. One of them is that data systems globally are antiquated. They are in the US too. That's a different story, but data systems are antiquated. We need a data modernization initiative around the world, and we chose countries that were developing, trying to help their data systems. And not just their systems, but personnel, technical personnel to work on data systems. Vaccination, being able to have countries, of course, procure and deliver vaccination, their supply chains and things like that, but also working on trying to help countries. Do you mind trying to? I'll fail there. Thank you. Trying to get countries to be able to build their capacity to manufacture vaccines, because one of the things that we learned is that when there's an emergency, countries will vaccinate their populations before they allow vaccine to be exported, right? That happened with many countries. And that's actually in the startup that I'm in, something that we're trying to do is help countries develop vaccine manufacturing. So there was data modernization, vaccine, and the other is respiratory disease surveillance. So we were working with over 100 countries to try to improve their disease surveillance. So we tried to come up with, focused areas that we'd be able to show results for short-term money. But the message I want to get there is we have kind of base money that we get every year, and we get big boluses of short-term money, and the big boluses of short-term money can be hard to deal with. Thank you very much. Yeah, thank you. Thank you. I wouldn't have been able to do that. And then a couple words about COVID and politics. And, Anthony Fauci was does everyone know who he is? Like, he's a big U.S. spokesperson for health, and I know him pretty well, and he's an amazing guy. He's probably the smartest person I've ever met. And he just wrote a couple of incredible articles in the New York Times about his career and kind of message for scientists. So one of the things that he just wrote in his opinion piece is, I always speak the unvarnished truth to presidents and other senior government officials, even when such truths may be uncomfortable or politically inconvenient, because extraordinary things can happen when science and politics work hand in hand. And I saw him speak many times, and he always spoke what he thought was the truth, and that's very difficult to do in those environments. So, he's someone that I really look up to. The last thing I was going to talk about is, is just one thing that came out of COVID, which is vaccines and vaccine diplomacy. And it's a really interesting issue, which is, so COVID happened. We were able to develop a vaccine within a year that was deployable. That was incredible. That's never happened before. That's going to change the world and make it so that I think that when there's a lot of efforts right now going on to try to speed up the development of the ability to develop vaccines and medicines against diseases. And this COVID example is going to make it so that people think they can do it much quicker than they could before. Now, most of the vaccines went to high-income countries at first, and then there was a big outcry about, rightfully so, about vaccine equity. And entities got together and created COVAX, WHO, the Global Vaccine Alliance, and CEPI got together and created, an entity that was meant to get vaccine donations and money and give vaccines to developing countries. There's a lot of talk over there about whether that was successful and whether it wasn't, but it was able to give away millions of vaccine doses and can be used to build upon for the future, I think. In addition, many countries strategically implemented bilateral vaccine donation. The US did it, China did it, Russia did it, which has also been very helpful and delivered a lot of criticism because of questions about what countries needed to do in order to get those bilateral donations. So that's something going into the future that the world is going to have to work on, which is how do we get vaccines equitably to countries in the world where there's an outbreak. We've learned that outbreak, a threat anywhere, like I said, is a threat everywhere. So it's not just the right thing to do, it's in our interest to do it, but countries definitely want to vaccinate their own populations first. I just have some data here. COVAX, despite all of the criticisms, was still able to, still able to get, billions of doses of vaccine, even though many countries are upset that they didn't get what they needed. When I went to Georgia, the country of Georgia, and met with the Minister of Health in June, he looked at me and said, "Can you help me get a refund from COVAX? They haven't given us what they needed." this just shows vaccination rates in 2022, and you can see that many countries did have high vaccination rates, and a lot of them are high-income countries, but some of them are low-income countries, and they either got donations. For example, Chile bought vaccine from China. Cuba produced their own. So there's a lot of models about vaccine, and I think that we'll have to learn from that on how we vaccinate the world in the next pandemic. And then the last slide I had, one of the things that was my major work for the past 3 years was we decided that instead of having CDC overseas staff purely based on funding from a single disease, we were going to get funding to be able to put staff overseas permanently, looking 20, 30 years ahead, as part of the U.S. national security for global health security. So we had an intensive effort to get money, which we got to put, and we now have people in over 60 countries who are funded with what I said, base funding, not one-time funding, to have a global overseas presence as part of our national security. And we do that, in the context of our mission of working globally to help protect Americans, but it helps protect the world, and increase the world's health security and ability to respond to infectious disease threats. So we have offices now, the red and the pink are where we have coverage. So we expanded greatly and are going to be able to keep that hopefully for the next 20 or 30 years. Okay, so I just touched on a bunch of things quickly. I'm ready to answer questions, but I did want to acknowledge some people who really helped me out and, gave me good ideas for over a number of years for presentations on diplomacy and how things are changing and development. And I want to thank CDC staff who have helped me greatly in learning about, all the things that I was talking to you about. And then I'll just leave this. This is the house I want to buy in Devon, where I was over Christmas and New Year's. I don't know how many of you are English, but Devon is one of the most beautiful places now I've ever been, and I want to go back and move there. So that's my goal, is I want to have that house right there. Thank you very much for listening. I'm happy to answer any questions.
Yes. Thank you. And I know, Beatrice, you have a question you would like to ask?
So my question is, what are the main areas that need focus globally to help prevent and respond to epidemics?
Yeah, so, I think that some of the biggest issues that we have are, there are specific technical issues, data sharing, agreements about data sharing, because countries have their own rules and regulations which they need to have, and we don't really have great systems for sharing nationally internationally to be able to know what's going on. We do for genomics, but we don't for epidemiologic data. So that's one of the things. I think another one is country technical public health capacity and working to build, having countries not rely upon experts from outside to come in, but really being able to build their own capacity. And then there's I think that we need we need to make WHO a strong coordinating body that everybody buys into, and we're getting there, but I think that international coordination is always very difficult, and it's probably the most important thing looking at trying to how to identify and respond to pandemics.
Any other questions? Yes.
Thanks for that, Mitchell. It's fantastic to hear your insights. Thanks for that, Mitchell.
Sure.
Yeah, really love your insights there. I guess two questions you touched upon. First, regards to receiving funding from Congress, and whether there are any kind of key metrics that you think were kind of good tipping points to get buy-in. And I guess the second question was around the WHO and where you think reform should be prioritised there for future.
Yeah, okay. So I'll answer very quickly. We could spend a couple hours talking about that. As far as Congress and metrics, it's very difficult. When there's an emergency, they like to give us huge amounts of money and then say after 3 months, why haven't you spent it? And that's not really the way to build programs to prevent disease. I think there's two things. There's a major effort to develop metrics for capacity building that have like red, yellow, like green, yellow, and red lights, and to show like these countries have increased their capacity this much. So that's happening now, and it's kind of globally accepted and being tested. The other, for the US and probably most countries, is you need congressional champions, which CDC and public health don't have. That is, to me, probably one of the biggest things that we need, are champions in Congress. As far as WHO, it's hard. One thing is the way governance works at WHO. They have regional offices and they have their national in Geneva. The regional directors are chosen by the countries in their region and have no real reporting. The director doesn't really have authority over those regional directors. So they are not one coherent organization. They've tried to fix that with emergency response, where you have emergency response staff that are national and they supervise, like Mike Ryan supervising the emergency response in regions and countries. That needs to be kind of the way WHO works, I think.
Other questions? Yes.
Yeah, thank you for the talk. It was really great. And you mentioned that the CDC director is appointed by the president, right? So I assume he also has the power to fire him, right? And do you see that this political relationship impacts the mission of CDC, and does the 4-year election cycle have some of this political influence on the mission of CDC?
Yeah, so one of the things that's come out of COVID is a discussion of where should CDC, and this is valid for every country in the world, where should CDC rest? Should it be like the Fed in the U.S., which is kind of appointed by the president but has no real government oversight, or should it be just in line, President, Secretary of Health, CDC? So that's a big question that's coming up. If you are in line and part of the administration, you are part of the administration, absolutely. So what do you release data, but how you talk about that data is affected by, communications, which is affected by the White House. So there is a huge struggle in the U.S. about, what needs to be cleared, what should CDC come out with on their own, what does the White House have to approve. During COVID, the CDC director had very few just press conferences with the public, right? And when they did, it was as part of the entire U.S. government. So you can go back and read and look at, all the interviews and press conferences that were given, but I think it would be very hard to say that there's not political influence over CDC. And I think that that's pretty true around the world now. And that's something that every country is examining. And but the following question is then, what do you do about it? And where should CDC? One of the things you could do is you could have the director, the presidential cycle is 4 years, so you could have the director assigned for 6 years. Or you just have it hired by another body and they're not even part of they're part of the U.S. government, but they're not really under the control of the administration.
Oh, yeah. So we talked a little bit about the lessons learned from COVID for preventing sort of future epidemics. Should that fail, what do you think sort of additional steps need to be taken to mitigate the impact of any future epidemic?
Yeah, it's definitely, well, I'm not going to say it's definitely going to fail, but it's not, we're not ready to prevent every epidemic or pandemic. And we don't necessarily know what's next. So we have to be prepared we have to be prepared not just for COVID. We have to be prepared for whatever is going to come next that we're not expecting. So Tony Fauci will be the first one to say his biggest fear, and what he didn't think would ever happen, would be a pandemic that was a virus, a respiratory virus spread by asymptomatic people. He's like, there's never been one before. I hope that never happens. I don't think it's going to happen, but it did. So what is going to happen next that we're not expecting? So really, the thing that I think we need to do most is what makes people fall asleep and is really boring. So building health systems for disease surveillance, which is like bread and butter, like, collecting samples, investigating reports of diseases, having data systems in place to be able to analyze those, have different levels of people who are analyzing larger data, having response teams that go out. I think those are the most critical, like those public health building blocks, the most critical things that we need. And if you tell funders in Congress that, they fall asleep, right? That's just not that exciting. I love PEPFAR. I worked in it for 10 years. It's incredible. We provided antiretroviral, but like I said, it's great. You're saying we're going to buy antiretroviral drugs, put people on them, it's going to save their life. Like, that makes everybody jazzed. So we got to find a way to get people excited about, like very basic public health tools.
And we have time for one last question.
Very interesting talk. I have a question about the data sharing. I remember you mentioned that building the data sharing. Do you think it might be possible to build a data sharing system globally, like across the different companies, like maybe IBM and Novartis? Do you think it might be possible?
So I do think it's possible. There's a few things that have to be worked out. So here, one example is when there was influenza sharing, Indonesia got very upset because when they gave a sample from their country, and I don't know, US or Europe, a country in Europe developed a flu vaccine from that, they wanted some compensation for that. So we have to figure out what is fair compensation for giving samples for developing countermeasures. Another is, one thing we learned from COVID is when countries report, some countries have felt like when they report an outbreak, they're punished. People close borders, don't let their country come in, they stop trade. So you have to find a way that countries are not punished for reporting diseases. So these international health regulations that are, trying to be revised, that's one of the things that they're working on because, like I said, many countries feel like they're punished. Then there's anonymized data and people feeling confident that data that they submit is not going to be traced back to individual people or individual ethnic groups or, things like that. And that is way beyond me, but that is a real concern that people have. And so, that's something that I think the private sector probably has a lot to teach the public sector about how to manage data. So, one thing I was going to talk about was opportunities for private sector and public-private collaboration. And I think there are a lot. One of them is development of countermeasures of, vaccines and treatments. And another one is data, and data systems. Another one is supply chain. Everyone says Coca-Cola can get, I've never been anywhere in the world that doesn't have Coca-Cola, but it can be really hard to get a syringe places.
Fantastic. So this was our last question. We have some refreshments outside, some drinks outside the cinema. But before we go for refreshments, please join me once again to thank Mitchell for the presentation today.
Thanks. Thanks for coming. Thanks for coming. Stay for a drink. Hope to come back and talk to you again.